Good morning, everyone. Darshini will be presenting the case and it will be moderated by Professor Inian, Samarasam, Professor Balachander, and Professor Mohan will be joining us shortly. It's all yours, Professor Balachander and Professor Inian. You can take over now. I think you can go to Darshini, you can go to the full show mode because this is PowerPoint slideshow. Go to the slideshow. Yeah, go ahead.
Good morning, Dr. Balachander. You're muted, sir. Actually, we can't hear you. Good morning, everyone. I think Darshini, Dr.
Yes.
Darshini, you can start. I think Dr. Balachander is.
17-year male, resident of Andhra Pradesh, student. I would like to know the socioeconomic background. Came with the complaints of difficulty in swallowing for past 7 months. He was apparently well 7 months back when he had an alleged history of accidental consumption of bathroom cleaner. I wanted to know whether he was under any influence or not. He had consumed around 100 ml, following which he had developed diffuse pain abdomen with 4 to 5 episodes of vomiting, which was not blood or bile. There was no history of chest pain, no history of hoarseness of voice. There was no history of any cough or difficulty in breathing. Here I would like to know whether he had any history of odynophagia, drooling of saliva, or history of stridor. Patient was taken to local hospital where he was admitted and given IV fluids and few intravenous medications. A day later, he developed blood-tinged vomitus, but not associated with clots, about 2 episodes per day, along with black tarry stools. He was managed symptomatically, and in the next 4 to 5 days, his symptoms improved and he passed normal colored stool. He did not give any history, he did not receive any transfusion of blood or blood products, and he was discharged with advice to follow up after 2 weeks. At this point, I would like to know if he required any ICU admission, if there was any need for intubation or tracheostomy, if any endoscopic evaluation was done, and if they tried putting an NG during this hospital stay. So 2 weeks later, he was unable to swallow solids, but was tolerating liquids only. He reviewed in a local hospital and he underwent endoscopy and was told to have a block in the food pipe and was planned for endoscopic intervention to relieve the block. He underwent a surgical intervention where a feeding tube was placed. I would like to know, a week later, he underwent first session of endoscopy, despite which his symptoms there was no significant improvement of symptoms, and he was now unable to swallow even the liquids, and he was totally on the FJ feeds. He underwent 2 more similar endoscopic interventions at an interval of 1 month each. About 5 months later, he had now lost around 15 to 20 kgs of weight, and he was unable to swallow the saliva. So currently he was in grade 6 dysphagia, and I want to know the amount of feed which he was given during this 5 months daily. What was his appetite? Whether he was tolerating the feed or not? Did he develop any pain abdomen while receiving the feed? Did he require any hospital admissions during this last 5 months? So he was referred to a tertiary center for the further management. At present, he is unable to swallow even saliva. Weight has remained stable over in the last 1 month. So here I want to know if there was any increase in the feed intake and whether his appetite had improved in the last 1 month where he could maintain his weight. And he is tolerating FJ feed. So I would like to know the amount of feed he's been taking in the past 1 month. If there was any change from past 5 months to last 1 month. There was no cough or hoarseness of voice, difficulty in breathing or fever. In the past history, there were no significant medical illness in the past.
Can I interrupt you here, Dr. Darshini? Yeah. So basically, this patient history is quite important, as you know, in corrosive injuries. So just go back. So this is your first slide, right? So you said that you would ask history of odynophagia, drooling of saliva, stridor. Why is stridor important?
The stridor, as after consumption of any corrosive substance, there might be any laryngeal injury as well as aspiration. So and based upon the level of involvement, if there is a stridor, it is more suggestive of a laryngeal injury, and we might require an immediate tracheostomy in such patients.
Yeah, so the severity of injury significantly changes when there is a stridor. And what you would do to the patient, how you would do it also, the stridor would influence it. Go to your next slide, please. Yeah. So he was then taken to a local hospital and he had treatment. You have asked a few questions here at the end. So endoscopic evaluation. So when would you do an endoscopy for a patient with an acute injury, acute corrosive injury?
It is more advisable to be done between before 72 hours, not beyond 96 hours.
Okay. So would you do it for all patients or would you selectively do it? What is your, suppose a patient comes to you, how would you decide whether this patient requires an upper GI scopy, or would you do it for all patients?
So I would see the severity of the injury. I would see the hemodynamic status of the patient, and then I would, if the patient looks stable and if he can tolerate the endoscopy, then I would like to go with it. And in case if I feel the grade of injury is high, clinically higher, I would like to go for a CT directly and then assess the injury.
Okay, so you're saying you would not do it for severe injuries, correct? Is that your answer?
Based upon the hemodynamics of the patient.
Okay. What are the contraindications then? One is you're saying hemodynamic instability, correct? Yeah. So what are the other contraindications of doing an upper GI scope?
Sensorium of the patient, and in case if he has acute abdomen where or shows if there is a frank perforation, then I think we can directly go for upfront surgeries.
Yeah, Dr. Mohan has joined us. Good morning, Dr. Mohan.
Can I ask some question? Hello?
Yes. Yeah, you can go.
Yeah. Doctor, can you hear me?
Yes, sir. Yes, sir.
Supposing you're planning to do an endoscopy, what precautions you will take?
So I would like to use a flexible scope with minimal air insufflation during the procedure.
Could it be any person can do the endoscopy?
No, it should be done by a trained endoscopist, sir.
An experienced person should do it. In your symptom, you said patient had in the first slide, no? You said that the patient had a abdominal pain, something? Oh, yeah.
Yes,
What was it?
It was diffuse. Yes, he
Diffuse
developed
abdominal pain with 4 to 5 episodes of vomiting, and later on patient had some hematemesis and melena. What does it indicate?
This is suggestive of a gastric involvement, sir. I feel pain abdomen following ingestion is it's pointing towards involvement of the stomach, and also he has developed blood tinged vomitus, so that might show that there is mucosal injury.
So when you do an endoscopy, you just introduce into the mouth, and then you find suddenly in the throat there are visible ischemic changes, some kind of dark, necrotic areas are seen. What will you do next?
So
Would you proceed or abandon?
Like to see the distal injury also.
No. Otherwise, why endoscopy is done? What is the necessity of doing endoscopy?
To see the highest grade of injuries.
No. Endoscopy, highest grade. That is the answer. No, but endoscopy gives you a chance to assess the degree of injury, isn't it?
Yes.
Yeah, degree of injury. If the injury is very simple, grade 1, or sometimes these patients can be definitely be treated with conservative management and they can go home. So that to recognize what is the degree of injury, endoscopy is done in, as you say, when a patient has, when you pass an endoscope into the mouth, when you see a kind of necrotic areas or ischemic areas, better not to proceed further, then abandon your endoscopy, because the grade of injury is severe and you may perforate, cause complications. Okay. Would you place a Riles tube in such patients if you think?
So if there is a necrotic patch, then I think Riles tube would not help, sir. In the early injuries like 1 and 2.
Usually, no, if you think in a patient of corrosive where you say grade 3, grade 4, would you place a Riles tube or not?
No, sir.
Why?
So one, the Riles tube itself might cause erosion, and it might cause perforation, and also it increases the risk of reflux, sir. So which further causes damage.
So how do you feed the patient?
Sir, in grade 3 or grade 4 injury, we could directly we could take him for surgery and we can place a feeding jejunostomy.
Directly take him for surgery means for nutritional purpose,
If I may,
isn't it?
I may add here. So when would you actually then put an nasogastric tube? So you're saying that you would not put it if there is grade 3 or grade 4, or when there is a necrotic patch. So, and you also are saying that it also increases reflux and therefore stricture formation. So then what is the role of a nasogastric tube? Or would you put in a nasogastric tube at all selectively?
Grade 1 and 2 injuries, we can place a nasogastric tube. In 2B as well, sir. It provides early feeding as well as it gives us a pathway for later endoscopic dilatation.
Yeah, I think more than these, I think grade 1 injuries perhaps may not even need a nasogastric. So if it is less severe, you perhaps don't need. And the more severe ones, you need to be careful. The real indication is when you have short segment strictures, where for dilating short segment strictures, this can be used. So if there is a long segment injury, perhaps the role of a nasogastric tube is very less. And similarly, if it is a very high grade injury, grade 3B, grade 4, you need to be then very cautious or do not put a nasogastric tube. It's only the selective patients who the injury is limited to a small area, perhaps a nasogastric tube has got it. I think that is, as far as the nasogastric tube is concerned. Dr. Mohan, you want to?
Yeah, so two things. One is early endoscopy. Second is a nasogastric tube. Generally, I personally don't agree to a early endoscopy because it doesn't going to change your management decision. Right? It's only for triaging the patient. In early injury, you can discharge the patient, or in a severe grade injury, you admit in a ICU and monitor. Second is nasogastric. Generally, in a patient who has consumed acid, you generally don't put a nasogastric tube early. This comes later on when you find a stricture, as Dr. Inian has said, a short segment stricture, and but generally we don't place nasogastric tube because it causes more harm than benefit in patients with corrosive.
Exactly, I completely agree.
Yeah, that's correct.
And I guess one more indication for endoscopy, in addition to early discharge, would be to prognosticate these patients and to predict the stricture formation. So how does endoscopy help with the prediction of post, long-term strictures?
So if there is a 2B or grade 3 injury, then there are high chances of developing stricture after 3 to 4 months.
You
So
have,
in endoscopy itself, we can explain the patient that he might require additional procedures in the future.
you have to be a little bit more specific. So what is the stricture rate in, for example, a grade 2B injury?
Cases, it is 30 to 40% of the structure.
Much more. It's nearly about 60 to 70% if it's 2B. If it's 3 or 4,
It's 80%, 80 to 100%.
it's almost 100%. So I guess you can predict this patient is going to come back with a stricture if you have an endoscopic assessment. But I completely agree with Dr. Mohan that it's not necessary to do this in all patients in the acute setting. Okay. And then you also said that you would do a CT scan, right?
Yes.
You mentioned about a CT scan. So what is the role of a CT scan in the acute setting?
The CT scan can give us a better picture of the injury, sir, because in endoscopy, we cannot assess the depth of injury. However, in CT, we can assess the depth, and a single imaging can give us a complete evaluation of the esophagus as well as the stomach. And we can also see the chest.
Do you know of any grading system based on CT scoring system?
Yes. So in CT grade 1, the mucosa is normal. In grade 2, there is post-contrast mucosal enhancement, which is more, which correlates to grade 2B to 3 injuries. And in grade 3, there is loss of mucosal enhancement, gastric mucosal enhancement, which is more suggestive towards 3B and 4 injuries.
Yeah. So CT can actually replace significantly the need for an endoscopy. So you can use it for grading the injury. And as you said, there is this grading system, which there are 2 or 3 grading system, but at least you should be able to, tell at least one of these. Okay. So just go to your next slide, please. Can you move on? Yeah. So then he goes to another hospital. 2 weeks later, he goes to another hospital and he has an endoscopic intervention, right? Let's assume that he did not have an endoscopy during the first admission. And he goes to the hospital 2 weeks later and he has an upper GI scopy. Okay. So what is your comment on this? What is your comment on this endoscopy?
So after 3 weeks, it is better. It is advisable to go for endoscopy, sir, so that we can assess the stricture and we can also plan further dilatations.
Yeah, but would you do an endoscopy 2 weeks later? What is the time period where you would avoid an endoscopy, upper GI endoscopy?
Sir, it is advisable not to do from 5 days to 15 days. It is better to do after 3 weeks, sir.
Yeah, so if you miss that window of 3 days, then it's probably better to wait for about maybe even a month before you do the next scope because of the risk of perforation, right? So I think I would, Dr. Mohan and Dr. Balachander can also comment, but maybe 2 weeks is a little bit early to do a upper GI scopy on a patient who has not had one.
Yeah, we do it more after 3 weeks. Even here, 2 weeks they have done on after 3 weeks because 2 weeks he was not able to swallow solids. But a week later he went and got an endoscopy done. So it's preferably to wait more than 3 weeks, at least 4 weeks.
Ideally, 3 weeks is better because we have, by the time there is a fibrosis sets in, and so these patients are, the healing is almost complete and or it's undergoing, but there are chances of complications are less. So ideally 3 weeks above is ideal for an endoscopy. That's what I feel.
Sure. And Dr. Darshanik, then it says that he underwent endoscopic intervention, right? So, what are the endoscopic interventions that you are aware of in such a situation?
So in such cases, they can either just put a NG tube, or they can we can also dilate the strictures. But at 3 weeks, it is too early to start the dilatations. So I feel placing an NG tube, and maybe they were not able to place the NG tube, so then they would have gone for feeding jejunostomy. Maybe they were not able to manipulate the guide wire also, sir.
Okay, so one intervention is obviously dilatation, balloon dilatation. Or what are the types of dilatation that you know that you can perform in these patients? Endoscopy.
The pneumatic dilatation, balloon dilatation. I'm not sure.
What is pneumatic and balloon?
Sir, in pneumatic balloon and metallic dilatation also, sir.
So
We also,
pneumatic and balloon is same, no?
yes, sir. Sorry.
Yeah. So another is, one is the balloon, another is
Metal. They
metal.
use.
Is it metal?
There are dilators, sir, which they just
There are
pass
some
through.
Savaricula dilator.
Savaricula dilators.
Yes, yes. So which one you choose where? Would you use a balloon or a Savaricula when there is
The
stricture? Or where will you use balloon actually?
The balloon is generally used for a very short stricture, sir, and Savaricula are generally used for long segmental strictures. Not
Sometimes when
long.
sometimes when the patient has a upper esophageal close to pharynx, no, just that area in the upper esophageal strictures close to the pharynx. So balloon would be ideal in such patients. So otherwise, down the lane, you better is to go for a Savaricula dilators. What?
Generally, dilated are two types, basically over the guide wire or through the scope. Okay, over the guide wires are basically the Savaricula ones, which push dilators, which are gradual dilators, and then pneumatic balloon dilatation. Balloon dilatation are mostly through the scope dilators for short strictures. But before going for endoscopy at 3 weeks, do you want to do any imaging?
Yes, sir. I would like to do a barium esophagogram, sir.
Yeah, that is very essential. But we all feel that you should have a clear roadmap before doing endoscopy and endoscopic intervention.
In this patient, no, go ahead. Next slide.
What is there a role of endoscopic steroid injection? Because that is something that has been talked about in the literature. We don't have much experience, but what are your thoughts on that? I mean, does it help
No, sir, it doesn't help in stricture prevention, sir.
There is literature for and against it. We don't have much experience in this, but I think you need to know what is the latest on this. There is also literature to say that it helps in reducing the stricture rate. But
yeah, if there is a literature saying that when you're dilating a stricture, intralesional triamcinolone acetate sometimes helps in reducing the fibrosis, so that when the patient's interval of dilatation is prolonged. So it has been done in some centers, and they are telling that these are the patients when you can prolong the session of dilatation. There is a fibrosis is prevented, and they are able to swallow or eat better. So there is a role, intralesional injection of steroid at the site of stricture, but there are not much literature supporting it, but it's like that. But there are literatures.
And the other thing is the use of stents. Again, there are biodegradable stents in this situation, but generally speaking, we don't use stents, but I think that is something to be avoided. Okay. Yeah, go ahead.
So a week later, he again underwent first session of endoscopic intervention, despite which there was no significant improvement of symptoms. And he was now unable to swallow even liquids and was totally on the FJ feeds. He underwent 2 more similar endoscopic interventions at interval of 1 month each. About 5 months later, he had now lost 15 to 20 kgs of weight and was unable to swallow the saliva.
When you do the endoscopy by Savory Gillard, how do you start?
We use 3 dilators of 3 consecutive diameters, not one with the moderate resistance. We stop with that, and when we do the second intervention, we start with the ones which we had stopped, sir, which had moderate resistance.
When do you think that you have achieved optimum dilatation?
At least the target would be 14 mm of the diameter.
When the patient is able to take
Which will
the normal diet, yes, up to 14. No? Supposing when you do a patient dilatation, suddenly you suspect a perforation. How do you recognize?
so there would be
It could be due to
onset
guide
chest
wire
pain.
also. It could be due to guide wire perforation, or could be due to the dilator itself. So how would you recognize on? Any idea?
Maybe we could see 2 lumens, sir.
No, the patient says something, no?
He has severe
The patient says, suddenly the patient says, when you're dilating, if you suspect a perforation, the patient says sudden severe pain in the chest. That is the first symptom the patient says. Then when you examine, what you get to know? Clinical examination.
Sir, on a chest X-ray, we can see mediastinal winding, bilateral pleural effusion, or air fluid
on
in the
investigation.
mediastinum.
That is on investigations, but clinically, you can also recognize such patients who have perforation. What is that clinical? Clinically, you can see.
Air entry, sir?
You see the patients develop surgical emphysema. You can feel the surgical emphysema in the neck predominantly. No, suddenly you can see after some time. So that shows that these patients have undergone a perforation. So you abandon your procedure and try to resuscitate. Okay, go back next.
Okay, please proceed.
About 5 months. About 5 months later, he had now lost 15 to 20 kgs and was not able to swallow saliva. So here I would like to know the amount of FJ feed which he was given daily, and how was his appetite, and whether he was tolerating the feed or not. Was it a home-based feed, or it was guided by a nutritionist? Or during this period, was he having any recurrent colicky pain abdomen while taking feed? And did he require any hospital admissions in the last 5 months?
Okay. Yeah, go ahead.
Go next.
He was later referred to a tertiary center for further management. At present, he is unable to swallow even saliva. Now, the weight has remained stable for last 1 month. He is tolerating FJ feeds, and there is no cough or hoarseness of voice, and no or difficulty in breathing.
So how will you proceed here? You said that unable to swallow even saliva, and then what do you want to do here further? Can you hear me?
So I would like, yes, sir. Yes, sir.
Yeah.
For I would like to assess his nutritional status, sir. At present, I would like to see his general condition, the WHO performance status, whether he is able to do spirometry or not, and if he is tolerating FJ feeds or not. So after the nutritional rehabilitation, then I would like to consider further surgical interventions.
When would you say that these patients have failed the dilatation? Sometimes no, the patients are referred for surgery as a cause that they say the patient is failed for dilatation. When do you say patient has failed endoscopic dilatation? What is the criteria? Any idea?
If he has not, sir, if he has not achieved the diameter of 15 mm after 14 mm after 5 endoscopic sessions every 2 weekly, then it is a failed endoscopic procedure, sir. Or and in case if the dysphagia has developed within 4 weeks of achieving a diameter of 15 mm, then also it is a failed endoscopic intervention. Or in case if he has developed any endoscopic related complication, then also it is a failed procedure.
Okay, you go ahead. History wise, okay. Next slide.
Past history had. So to summarize, 17-year male with no known comorbidity and psychiatric illness presented with alleged history of consumption of 100 ml of toilet cleaner 7 months back, following which he developed diffuse pain abdomen and vomiting. He had the history of hematemesis and melena a day after. He required admission and discharged after 5 days. Following discharge, after 2 weeks, he developed dysphagia grade 4, underwent endoscopy and feeding gynostomy. He received 3 sessions of endoscopic treatment, despite which the dysphagia progressed to grade 6 over next 5 months. And he had a significant weight loss.
Sure. So this is almost a classical history of somebody who's had significant corrosive examination. Anything significant?
The patient he has a moderate build and moderately nourished, and he's spitting saliva frequently. His breath holding time is 44 seconds, and his BMI is 19.2, which is good, and his WHO performance status is 1. He has no tachycardia, no fever. His oral cavity examination is normal, with the healthy mucosa in the tongue, mucosa in the oral cavity, tongue, and visible part of pharynx. There is no scarring. Mouth opening is adequate, 3 fingers. Nasal examination is normal, and he has no signs of dehydration.
Okay.
On abdomen examination, the abdomen is scaphoid, umbilicus is central and inverted. FJ tube is seen lateral to the umbilicus on left side. Vertical midline scar of previous surgery healed by primary intention is seen. And rest of the inspectory and palpatory findings are normal. So.
Okay.
On percussion, the liver span is 13 centimeters, and digital rectal examination is also normal. So respiratory system examination is normal with bilateral equal air entry, no crepitations or added sounds. Other systemic examination is also normal.
Sure. So
I would like to give a summary here.
So this patient essentially now requires surgical intervention, right? So this patient now comes to you. Just tell me, how would you assess the nutritional nutritional status of this patient? You said the BMI, you assess the weight, BMI. What are the other ways of measuring the nutritional status?
So we can go for subjective global assessment, where we also see the muscle strength, any temporal hollowness, suprasclavicular hollowness. It also includes his appetite, weight loss. So one is through subjective global assessment, and secondly, we can also go for a hand dynamometer, which is also a good tool to assess the muscle strength, which indirectly gives the nutritional status.
So there are, and what other blood tests would you do to assess?
So for the nutrition, or
Yeah,
in?
nutrition. We're talking about nutrition.
I would like to get an albumin, serum albumin done, pre-albumin done, and even serum transferrin also gives the nutritional status.
So after assessing the nutritional status of this patient, let's assume that you're planning surgical intervention. Okay, so how would you go ahead?
So first, I would like to go through all his previous records, sir. I would like to know in the endoscopy, what was the severity of injury, what was the extent of injury, proximal limit of the injuries.
So we can go to the endoscopy.
So the upper GI endoscopy shows esophagus, extensive circumferential lacerations noted all over the esophagus. OG junction is at 40 centimeters. Extensive gastric corrosive burns, and the scope could be passed across the antrum, and T1 and D2 are normal.
Okay. So is that an adequate report, or?
I would also want to see the pharynx, sir. I would like to have a hypopharyngoscopy and laryngoscopy also, sir. Because now he's spitting saliva. I'm assuming it to be a very proximal strictures.
Okay. I think he's had another upper GI endoscopy. This is when he had presented a month later. Okay, so this is about a month later.
So because 20 centimeters from the incisors, there is narrowing in the esophagus. Scope could not be negotiated beyond.
This is the time when he was not able
So
to.
there is a stricture in the.
Okay, so you've got a scope. Looks like there is a dense stricture beyond this point, 20 centimeters. What next? Patient not able to swallow saliva. Patient is spitting out saliva. Patient comes to you.
So now we know, so there is a stricture in the upper esophagus, and also there was gastric erosion. So I would like to plan a colonic conduit bypass, sir, for this patient.
But what
After
other
doing the,
what other assessment would you want to do? Because
I would like to do a laryngoscopy, sir, to see the vocal cords.
okay.
So, I want indirect laryngoscopy reports.
So you would like to do a NPL scopy. Let's see if we have a scopy available. Okay, a video laryngoscopy is available.
So oropharynx is normal, epiglottis is normal. Few fibrotic bands are noted. Few fibrotic bands around the epiglottis with restricted normal and mobile vocal cords.
So the vocal cords are moving. There is some fibrotic bands around the epiglottis. Let's say the PFS is a little bit of scarring in the PFS. So what next?
So I would also want to get a barium esophagogram, sir, so that I can see the diameter, sir, the proximal diameter before the stricture, sir.
Okay. Many times the patient may not be able to swallow anything, but it's definitely useful to get a barium, an upper GI contrast study. And if you're doing an upper GI contrast study, what is the contrast that you would use?
So we use barium, sir.
Yeah.
And
so probably thin barium. Never use gastrographin in these patients because
I think it has a risk of aspiration pneumonitis.
Yeah, so particularly proximal strictures, risk of aspiration, so never use gastrographin. So if we can have a barium picture, which was done.
We have a barium picture when it was done just before starting dilatation, sir.
Sure,
We-
yeah, we can show that barium picture. So what's your comment on this barium upper GI swab?
So here the hypopharynx looks normal. Then, sir, in the lateral, in the lower down images, I can see as segmental strictures, sir, in the upper esophagus. Yes, it is just behind the trachea and larynx.
In the first picture, what do you see? Doctor, the first picture, describe
Here
the
there
first
is-
picture. The first picture on the left.
Yes. So there is the hypopharynx looks normal, and the upper esophagus also shows normal. Then there is a beaking and in the mid part, and then there is a long segment, a long strictures.
Long segment stricture with a, you can see the barium column also above. Barium column. See,
Yes.
some barium is held up.
Yes.
It's a
Yes.
long stricture. Okay, okay. That's what is there. Okay.
So on the barium, you're saying there is a proximal stricture, short segment, and there seems to be a relatively, probably a segment of esophagus which is dilated, and then again a long segment of stricture in the thoracic esophagus, right? So there may be an intervening part of segment of esophagus which is relatively normal. Okay. So now how would you proceed? So there is a proximal stricture. So there is a pharyngoesophageal stricture proximally, relatively normal esophagus in between, and then a very long esophageal stricture in the thorax. So this is the situation. What we don't know is the situation of the stomach, right? Still, we do not know the stomach situation. It doesn't, the picture here does not show the images of the stomach. We haven't gone into the stomach, or have the endoscopy was in the stomach, is it? The
Yes,
subsequent,
there was erosion.
yeah, the subsequent endoscopy, they were not able to go beyond beyond 20 centimeters. Right? So what we really don't know is the situation of the stomach at this point in time. So what next?
Before
with
that,
the
I want to
initial-
ask, Doctor, before that, I want to ask you, when will you take up this patient for surgery? What is the ideal time? Will you
At
take up
least 6 to
immediately?
12. No, sir. At least it
Which
requires
is
6 to
ideal
12
time?
months.
Huh?
6 to 12 months, sir.
Why? Why
It
such a
is
long
when
delay?
there is a prolonged catabolism in such patients, sir. So we would first cross the catabolic phase, and secondly, the strictures also would like them to get it matured. So that also requires at least 1 to 2 months before. Main reason being the catabolic phase of the patients.
Okay. So you will take, there is a time period, interval. So
It's
based
6
on
to
that
12
one,
months.
yeah, that's correct. Okay. Now, what is your plan here?
So as the initial upper GI endoscopy showed that the stomach is also unhealthy, so I would consider for a colonic conducer. And there is a high upper.
Yeah, you would go for a colonic conduit, a coloplasty, esophagocoloplasty. Which, the colon means there are several, right, middle, left colon. What is your choice of conduit
Left
in the
colon,
colon?
sir.
Yeah, which site you will take?
Left
Based
colon,
on
sir.
left colon, based on which the blood supply?
It is based upon this ascending branch of left colic artery, sir.
Why do you want to choose the left colon? Why not right or middle? Why do you want to choose the left?
So left provides us a longer length. It can reach till the pharynx, and it has a more reliable blood supply, sir. Whereas the right colon has a variable blood supply. So I would prefer doing a left colonic.
Any other advantage of left colon? You said
The
few,
luminal-
but there are some more.
Lumen also, sir.
It matches, no, lumen match. Anything else? What is it? If you compare stomach and colon, what is something which is the colon has some good quality? What is that? It is
Acid resistance
acid
and
resistance.
less.
So you said regarding the blood supply, right colon, left colon. What is the difference?
Sir, in the right colon, it has a variable blood supply, sir. Left colon has a consistent blood supply from the middle colic.
Would
from
you
the
choose?
left colic.
Would you go for an isoperistaltic or antiperistaltic colon conduit?
The isoperistaltic, sir.
So you choose the left colon, not the right colon. So in that case, if you are choosing the left colon, your blood supply is what is you said?
Ascending
Left
branch
colic?
of left colic
Left-
arteries.
So which are how will you, okay, you are planning, for the coloplasty, So how would you measure the length of colon?
So I will measure it from the tip of the earlobe to the origin of the blood vessel, sir. So that should match the mesenteric side of the colon, sir.
So you will do two measurements. One this and another is the colon itself,
Yes, sir.
What do you want to measure? What is the rationale behind measuring it?
So to avoid tension on the conduit, sir.
To avoid shortening or length or redundancy, say like that. To avoid a short colon or redundancy of the colon. Okay? Okay. So supposing you are taking the left colon, what about which are the blood vessels which you would like to occlude?
So I would like.
Yeah, tell me. Because the colon has to go to the neck,
Yes.
So
I would like to divide the middle colic artery proximal to the diversion, sir. Proximal to the branching of left and right branches.
So you would, which is the critical point in that case? So you're dividing it. So how does the blood? How does the conduit get the blood?
It's through the marginal branches, the marginal artery of Brummond.
Arteries. Yes. Inian Samarasam or Dr. Mohan, please go ahead.
Yeah, before going into surgery, what you will discuss with the patient? How will you explain the surgery? What all things you discuss with the patient, which is very, very important.
Because it is a high stricture, I would first explain him the risk of permanent tracheostomies. And I'll explain him the surgical. I will take a proper consent for the surgery, sir. I will explain him all the complications which can occur in intra-op and in the post-op period, sir. And he might require. Now we'll tell him, sir, we are using a colonic conduit, so you will require 3 anastomosis. So there are chances of anastomotic leak, and in the future there might be esophageal stricture and risk of aspiration. So I'll also tell him the position he has to lie down. He has to be 45 degrees upright. And
the main important thing is the nature. It's going to be a major surgery. One second is going to be a life-changing surgery. Like he may require tracheostomy, which initially may be temporary, may lead to permanent. So he has to, for swallowing, he may have to lose his voice. Right? This has to be very clearly explained to the patient, and then let him decide whether he wants the surgery or not. Because certain patients who are in certain profession wants to have his voice intact. And if you tell them very clearly, way between your voice or swallowing, and many of our patients, they prefer swallowing to voice. This is what I have personally seen, but we have to discuss this very clearly before taking up for surgery. Dr. Inian.
Yeah, completely agree. And in addition to this, the patient also needs to know that the swallowing, they have to relearn to swallow, particularly when you have a very high stricture. The patient thinks that, post-operatively, before they go home, they'll be able to eat normal food, which most of the time, majority of the time, they will not be able to. And it may take 3 months, 6 months, they go home with the feeding jejunostomy. So, and they relearn to swallow and swallow therapy. So it is a long process. Tracheostomy, but even if it is a tracheostomy is not there, you need to tell the patient that the swallowing, the relearning the swallowing, and that thing may take up to 3 months to 6 months before they are able to take by mouth. So that is very crucial. And of course, this perhaps not in this case, but this was an accidental ingestion, but proper psychiatric assessment and psychological support is necessary for these patients, because these are young patients. Many times they do it impulsively, but they may have a psychiatric issue as well that needs to be addressed before you embark upon a major surgery like this. So that is very crucial. But I think one thing that you need to be able to substantiate or tell us, at least for the exam, is resection versus bypass, but because that is an important thing, and I'm sure you know this. Just very quickly tell why you think, what is the advantages and disadvantages? Why can't we do a esophagectomy? Why
So
are you?
we will encounter dense adhesions in the posterior mediastinum, sir. So bypass is more preferable, sir.
What is
And secondly,
what is the risk of cancer in these patients?
sir, it is very low, sir. It is hardly 1.3 to 1.9%, and with the latency period of some 15 to 40 years, sir. And moreover, sir, in India, people generally consume acid, so it's a very low chance because the mucosa is already burnt, and sometimes there might be mucocele as well, sir. But removing the native esophagus it's a risky procedure, sir. There might be injury to the adjacent trachea, thoracic duct.
Particularly when it is a high stricture, when it is in relation to the tracheal tree, it's advisable not to remove it. However, lower strictures, there is a role. But yeah, you should be able to substantiate why you're doing this procedure, why you're not doing a resection. And in this patient, if you're doing a bypass, you need to also tell the patient about the cumulative effect of smoking, etc. So although the patient, you leave the native esophagus behind that is damaged and you're not removing it, there is a very, very small risk of cancer. So smoking, alcohol, etc., post-operatively, I think the patient needs to be warned about. So that again forms part of your counseling, okay, before you operate on these patients. Dr. Balachander asked you about the left colon versus right colon. Again, you need to be able to tell why, what is the blood vessel you're going to base it upon, etc. So in this particular patient, basically there is a pharyngoesophageal stricture. Let's assume that there is a short segment stricture on the top. Then there is a relatively reasonably okay esophagus in the middle, maybe 5 or 6 centimeters, and then a long stricture. So where would you do? And what is the, you got a relatively normal esophagus or a dilated esophagus in the middle, let's say 5 or 6 centimeters. What is the risk of leaving that esophagus behind? So you do a colon bypass, you do a bypass, you're leaving the native esophagus behind. What are the subsequent long term, this is a 17-year-old patient, right? You told about malignancy, but what are the other problems that this patient can have? Even if the operation works well, what are the things you need to know? Because this patient has got another 70, 80 years.
He can develop a esophagocele, sir. There would be mucosal mucus hold up in the retained segment. So it is basically a closed loop obstruction thing, sir. It can perforate in the later periods.
The risk is small, but however, it is there. That segment of esophagus, if you do a bypass, can usually will drain because there is barium going beyond. Okay, it's not a complete obstruction. So still the mucus will be able to drain. The risk is small. However, if that long segment stricture completely fibrosis, then the risk of mucosal becomes, is there. So you need to image these patients because these are young patients. So perhaps they need long-term follow-up also. So would you do this? So let's say you're using the colon, right? So in your assessment, you've not told anything about assessment of the colon, what colon you're using. But how are you going to assess the colon before you put it in the neck?
Sir, he's a young male, so he doesn't require any imaging per se for assessment of colon, sir.
So you wouldn't do a contrast study of the colon? Prior to talking about preoperatively, there is a barium study or a gastrographin study or a colonoscopy required?
So colonoscopy can be done, sir.
No, you cannot say it can be done. What will you do is the question.
Sir, keeping his age in mind, I think I would not do any imaging, sir.
Balachander, Dr. Mohan?
Yeah, there are two things to evaluate in colon. One is the mucosal lesions, where you should generally, any patients above 40 years need to have a colonoscopy before considering colon as a conduit. Second is its vascularity. And general, in the past, we never used to do a study to do the vascularity, but after a CT scan with the vascular reconstruction is available, we generally nowadays do see contrast CT with vascular reconstruction to see the vascularity of the colon. But ultimately, what determines is on table how the colon is. But in general, vascular evaluation and a mucosal evaluation in an elderly patient should be.
Yeah. So
This patient is a younger patient. So it's not necessary to evaluate the colon, number one. Number two, regarding the vascular, evaluation, because he's young. So I think on-table vascular evaluation by, occluding the blood vessels and observing the blood supply itself is enough. There are studies from All India Institute of Medical Sciences where they have assessed some cases and they have published that their inference says that it's not necessary in young patients. So most of them can be on-table assessment itself is enough to determine the vascularity.
So in our center, we still do a contrast study for the colon, regardless of the age of the patient. It also gives you an idea of, particularly if you're using the left colon, how redundant the sigmoid colon is, whether you'll be able to, achieve. It gives you a rough idea. So we still do a gastrographin enema. We don't do a, vascular assessment. So that is not part of the routine assessment. However, if it is a redo, definitely this needs to be done. Both needs to be done. If it is a redo operation. For a first-time operation, perhaps routine CT angiogram is not necessary. Okay. So post-op, what do you expect in this patient? Let's assume that you've done a colon biopsy. what would your post-operative routine be?
I would like to start feeding from day 0 itself, sir. I would give him a dextrose-based feed, DNS feed from on day 0 in the evening, and then from next day we can start elemental feed, sir. And on day 7 we can do a swallowing test. We can give him a solid food. If he swallows, then we can start him orally, sir.
See, when you have a high stricture like this, most of the time the patient will not be able to swallow without aspirating because you're putting the colon very high. So if you're doing a pharyngocolic anastomosis, you will never be able to start feeds that early. If you're doing a esophagocolic anastomosis below the cricopharynx, perhaps that's okay. But if you're doing a pharyngocolic anastomosis, that's a high anastomosis in such type of strictures, then I think you need to be very careful before you do a contrast study, because generally they take much longer time. They need to relearn to swallow. So if it is a very high anastomosis, there's no big rush to do all this. You can wait. I would get an assessment, a vocal cord assessment post-operatively. Make sure the vocal cords are working properly. Make sure that they're not aspirating, because the last thing that you want is this patient aspirating and going back to the ICU. So you don't want to do that. So be careful when you refeed these patients, particularly high strictures, and perhaps they need swallow therapy. They need those kind of things before you go in. And generally, a contrast study is not necessary, because anyway, the anastomosis is in the neck. If it leaks, you're going to know. So there is not even a rush to do a contrast study in these patients. You can just take it slow.
Yeah, another thing in the high anastomosis, tracheostomy is a must. And after careful assessment only, after the patient starts eating only, you have to just, with the advice of an ENT specialist, you have to remove it. Otherwise, sometimes these patients, if you remove it hurriedly, they may go for aspiration and problems. Another is putting a rice tube in situ in a high anastomosis. I think Dr. Inian, what's your advice? That what we do is we keep in a high pharyngocolic anastomosis, we leave a rice tube. We do not remove it actually. When we want to give the feed orally, we try to do an endoscopy and pass a guide wire and see how is, just observe through the endoscopy whether we are able to negotiate an endoscope across it, and then if you are able to negotiate to a satisfactorily through a guide wire, then we withdraw the rice tube and then observe the patient repeatedly. Some of the patients whom you remove the rice tube in a high stricture earlier, that these patients, they go for a stricture and then you will not be able to even put a guide wire in these cases. So we have to be very careful in high strictures. So leave a rice tube in situ, assess it post-operatively before you feed them. Then once you're satisfied, then you're able to pass the scope fully into the colon, then you feed these patients.
Sure. I think leaving a rice tube a little bit longer. Yeah, I think normally we put a rice tube, and but we don't leave it for very long. Basically, these patients also have a feeding jejunostomy. So they would resume feeding through the feeding jejunostomy, and this process of relearning to swallow, all that is perhaps easier without a tube in the nose. So that is there, but definitely we leave it for a little bit long. I think if it's okay, we could perhaps wind up. There are a few questions here in the chat box. One is the ideal time to perform a feeding jejunostomy. And I think this question is regarding when to do a feeding jejunostomy in the acute setting. Dr. Mohan, you want to take your question?
Yeah, generally we wait for a week or so, whether we'll see the patient is able to can swallow his saliva first. If he can swallow his saliva, whether he can swallow liquids, and then we wait for generally a week. If patient is not able to swallow, given a saliva after a week, then we go in for a feeding generosity.
Yeah, definitely. I think before the patient gets discharged, we can perhaps plan for a feeding tracheostomy if it's a significant injury. The next question is, once a mucocele develops by chance, how do we manage? So we were talking about mucocele forming. Again, it's a rare occurrence. It is not something that you would, it happens in every patient. Dr. Balachander, regarding how would you tackle a mucocele in the chest post-operatively? This is long-term.
Yeah. Usually you have to do it. I mean, unless the patient is symptomatic, I think you have to go for a kind of a thoracotomy. But we have not seen any such cases.
We have seen only one, and we had to go into this and put in a jejunum to drain it. But it was a very large mucocele that had formed many years later. Following the surgery.
That is why they say that when you don't divide the esophagus, in the AIMS study they have mentioned, they don't divide the esophagus. They do the coloplasty, just leaving behind. I don't know. The idea is being secretions to pass on. I don't know what's that. But we generally divide it and do a coloplasty or a pull-up, gastric pull-up. What's your take up?
One of the problems is when you have a long sump, like if the esophagus is normal in the neck or up to the upper thorax, and you do an anastomosis higher up in the neck, you leave a sump of the esophagus. So the food sort of passes down through the normal passage and then sort of has to reflux back. So that is one of the problems if you don't ligate the esophagus. But again, this has to be taken on its merit, I guess, depending on the patient. Whether you ligate it or not, how do you deal with a sump when you have a long normal esophagus? If you don't ligate it, then it can become a problem. There is another question on right versus left colon. I think we have discussed it based on what blood supply, whether you're going to do it isoperistaltic or vice versa. So all that depends, and also the length. So it is a matter of choice. I guess the key is to have a well vascularized colon without tension. And however you achieve it, I think it doesn't matter. And last question was, for small isolated perforation following corrosive injury, is stenting an option? So the question is, if you perforate the esophagus, okay, sorry, it's actually not iatrogenic perforation. So the question is regarding a small isolated perforation following corrosive injury. So a primary perforation following a corrosive injury, how would you manage? Would you put a stent? Dr. Mohan, you want to take that question?
There is a perforation after.
So basically, it's unlikely to have an isolated perforation. Usually, the perforation, if it is after a corrosive injury, would be that the rest of the mucosa is going to be very unhealthy. So I guess you need to be careful. The question is whether you can put a stent just to tide over the crisis. But what you would be dealing it with is, necrotic esophagus. So really, it's unlikely to be just one small perforation, the rest of the esophagus being normal. So stenting, you need to be very careful. And removing the stent may be impossible. Once the stricture forms, you may not be able to remove the stent. We've had instances where it was stented. The stent cannot be removed because there is a stricture proximal to it. And these patients, we've done esophagectomies purely because there is a stent which cannot be removed. So be very careful of stenting esophagus in this situation. Dr. Pradeep, I think we will wind up. I think we've got senior surgeons, Dr. Kapoor, Dr. Shastri, and Dr. Yadav here. And over to you, Dr. Pradeep.
I think you have done well. Regarding the colonoscopy and angiogram, as the moderators have highlighted, the guidelines doesn't support, but there are indications for selective cases and also institutional preferences. Like our institution, we do colonoscopy because we did find some incidental surprise findings during surgery. After that, we make it routine to do a colonoscopy. Angiogram, invasive angiogram is not required, as Mohan has highlighted, that CT angiogram is good enough to sometimes you might find a rare anomaly which you might have to change the decision, but it is not mandatory as per the guidelines. Regarding the pharyngocoloplasty, yes, in this patient there are some adhesions around the epiglottis. So such a situation, if you are planning a pharyngoplasty, we do laser additional lysis pre-operatively the ENT people will do it so that the chance of aspiration will decrease. So we usually do it about 3 months prior to our definitive surgery, so that after laser additional lysis, it will mature and become supple by the time you go in. And we don't routinely do tracheostomy in these patients because most of them, even if you do colopharyngeal anastomosis, they need not aspirate. But if the patient is aspiration, then on demand we do a tracheostomy. This is a protocol which we follow. So let us have opinions of other people like Shastri, Professor Kapoor, Professor T.D. Yadav.
Just a brief comment. Yes, she has done fairly well. Only one reason she gave for delaying the reconstruction for 6 months is to offset the catabolic phase. The catabolic phase after any injury doesn't last for 6 months unless there is a serious complication. It is not the catabolic phase, but the reason to delay the reconstruction is to wait for the healing process, the fibrosis to complete. The second one was about the mucoceles. Yes, we have seen a few of them after long periods, say 10, 15 years after, particularly when you had to do a gastrectomy also in addition and severe the esophagogastric connection. So in such cases, the esophagus was, the stump was jutting into the, through the hiatus, and we could use the same, jejunum, because we had to do a colojejunectomy there, the jejunum for draining the mucocele. We had a mucocele of the stomach also. When the stomach was grossly fibrotic and it was just left behind, after 15 years, became so huge that it was causing compression of the anastomosis, and we had to drain that also. So these are just a few comments I wanted to make.
Morning, Pradeep. Good morning. VK Kapoor here. Hello.
Good morning, Kapoor, sir.
Yeah. So one general comment, this I have said earlier also, whenever you are showing or you are shown a report, there is no need to read it out aloud, because all of us have read it much before you read it aloud. So you have to analyze it and you have to give your interpretation. Don't read the report, don't read the numbers. Now, at the time of stricture repair, the severity of injury at initial upper GI endoscopy is of no importance, no use. What is important is the current status of the stricture. And to evaluate that, invariably, I would say almost always, you should have a recent endoscopy and or a contrast study. Most important thing is the proximal level of the stricture. That is there a normal esophagus, or are you going to end up having a pharyngeal anastomosis? Length is also important because length decides the response to dilatation. But once you have decided for surgery, then length is of not much importance. And diameter of the normal esophagus obviously is of no importance, because you are going to do a side-to-side anastomosis, because most of us would now do a bypass. Evaluation of the stomach is very, very important. If it has not been seen on the contrast study or endoscopy, then you have to do a CT scan to evaluate the stomach, because as Dr. Shastri said, that if you ignore a injured or scarred stomach, it can have problems. When you were asked to describe your plan of management, you just said coloplasty. That is not the complete answer. First, you have to say whether you are going to resect or you are going to bypass. Then you have to, if you are going to resect, then you should say which approach you are going to use. Then you have to say which conduit you are going to use. And if it is a colon, and if it is a right colon, you have to say whether you are going to include the ileocecal valve into your conduit or not. Then you have to say which route you are going to place if you are doing a bypass, which route you are going to use. Obviously, all of us would do the substernal, but you have to say that. And then you have to say how you would do the anastomosis. And here, of course, anastomosis will always be in the neck, but in malignancy, the site of anastomosis. So that should be the complete answer. Whenever you describe esophageal resection or bypass, in your answer in the first go itself, you have to include all these points. And you use the word that the blood supply of the right colon is not reliable. The correct term is not reliable. It is not consistent. Whereas the blood supply of the left colon is very consistent. So that is the correct term. And as Dr. Shastri already pointed out, the reason for delaying surgery for any corrosive injury for 6 months is to allow the fibrosis to the maximum and the stricture or the narrowing process to mature to its final level before you take a decision as to what needs to be done. So students, please send me a mail, bkkapoor.india@gmail.com. Write corrosive esophagus in the subject of the mail. I will be happy to send you some more reading material. Thank you. Thank you, Pradeep.
Thank you, sir. TD, any comment?
Good morning, sir. She is from our place, so I'm not going to talk about how she presented, but actually it was a good learning process for all of us. The only thing I want to say that the esophagus mucocele, I had one, and many years back, it was some compulsion to do a substernal. It was not corrosive injury. Substernal bypass we did. And what I did when patient became symptomatic, I did a CT scan, then I talked to my colleague in the international radiology, and they put a small tube, and then after aspiration, we repeatedly we put a sclerogen, and slowly it became all right. And then after that, patient had no symptoms. So I think international radiology can be used. That is the only thing I can say. Rest of the things are given. Thank you, sir.
Thank you. Can we wind up, Inian?
Yes, sir. Yes, sir.
Yes, sir.
Thank you, Dashnik, and thank you, Inian, Mohan, and DG Balachander, and other faculty as well. Thank you.
Thank you, sir. Thank you.
Thank you.